Good afternoon. Welcome to the 2015-2016 Influenza Kickoff webinar. Your presenter is Shannon McBee. She holds a master's in public health, and she is also a certified health education specialist. Shannon?
Thank you, Leslie. I appreciate you guys taking the time out of your day to attend this annual influenza season kickoff webinar. As Leslie said, my name is Shannon McBee, and I'm the influenza coordinator with the Division of Infectious Disease Epidemiology with the Bureau for Public Health. Flu season officially kicks off in a couple of weeks, October 4th to be exact. This webinar is intended for local health departments, sentinel providers, and influenza partners. Just some few housekeeping before we get started into the webinar. If you're viewing this webinar from your computer on Microsoft Live Meeting, you can use the volume on your computer. There's no reason to call in. If you don't have the option to use your computer, you can listen via conference call, but please mute your line. This webinar is being recorded and will be available after the webinar is complete on our website. And at the conclusion of the webinar, we will have a question and answer session. For those seeking CEUs, an email will be sent out with a post-test that you need to complete and send back to our training coordinator, Leslie. So let's go ahead and get started. We've got a few objectives for today's conference call. First, we're going to describe the components of the influenza surveillance program and the importance of influenza surveillance. We're going to summarize the 2014-2015 influenza season and review the roles and responsibilities of local health departments for the upcoming flu season. We will also describe the roles and responsibilities of the influenza sentinel providers and discuss key aspects of investigating a flu outbreak. We will also review the 2015-2016 flu vaccine and review influenza specimen testing and kits. And finally, today we will conclude with a description of the highly pathogenic avian influenza outbreak and West Virginia's response efforts. I will start today by describing the influenza surveillance program here in the United States. There are 5 major types of influenza surveillance here in the United States: viral, outpatient illness, mortality, hospitalization, and geographic spread. The first graph on slide 4 is of virologic surveillance for the 2014-2015 season. Virologic surveillance is laboratory testing surveillance using confirmatory testing methods by PCR or culture. Virologic surveillance comes from laboratories represented from the World Health Organization, collaborating laboratories, and the National Respiratory and Enteric Virus Surveillance System, who report the number of respiratory specimens tested and the number of positive for influenza types. A subset of these specimens are sent to CDC for antiviral testing and antigenic characterization. Virologic surveillance also includes surveillance of novel influenza strains. A human infection with a novel influenza A is a nationally notifiable condition. Novel influenza A viruses are human infections with influenza A viruses that are different from current circulating human seasonal influenza strains H1 and H3. The second type of influenza surveillance is outpatient illness surveillance. This is where sentinel providers come into the picture. Each week, enrolled providers report the number of patients seen with influenza-like illness by age group and the total number of patients seen. This information on patient visits for influenza-like illness is collected through the CDC U.S. Outpatient Influenza-like Illness Surveillance Network, or ILI-NET. You can see from this graph on slide 5, the 2014-2015 season is marked by triangles with a red line. This past season was similar to the 2012-2013 flu season. The third type of influenza surveillance in the United States is mortality surveillance. This is done using 2 systems. Mortality surveillance is rapid tracking of influenza-associated deaths. This includes influenza-associated deaths in persons less than 18 years of age, which is a nationally notifiable condition. Any laboratory-confirmed influenza-associated death in a child is reported through the system through CDC. During the past flu season, 144 pediatric deaths were reported. The second mortality surveillance system is a 122 cities mortality reporting system. Each week, from 122 cities, vital statistics offices across the United States report the total number of death certificates processed, and the number of those which are for pneumonia or influenza was listed as their underlying or contributing cause of death by age group. The epidemic threshold is a point where the proportion of deaths attributed to pneumonia or influenza is significantly higher than what would be expected at that time of year in the absence of substantial influenza-related mortality. Only during really mild flu seasons do we not go above this epidemic threshold. This is why you often hear on the news that we have an influenza epidemic. This is something that happens pretty much every season. Another way we measure the burden of influenza is through hospitalization surveillance. This system tracks influenza-associated hospitalizations in children and adults. We can look at hospitalization data several ways if we want to compare the burden a flu may have on a certain population. For example, on slide 9, this shows the past flu season was disproportionately affected by the elderly compared to the previous year. Lastly, states report to CDC the geographic spread of influenza in their state. Each week, the influenza coordinator uses statewide data to report West Virginia's activity as either no activity, sporadic activity, local, regional, or widespread. This measures the geographic spread and not severity. Together, these 5 categories of influenza surveillance are designed to provide a national picture of flu activity. So using the surveillance data that I just reviewed, I will provide you a summary of the past flu season. During the 2014-2015 flu season, activity began to increase in November and peaked in late December. This season was characterized as moderately severe and severe for the elderly. This was the 3rd season in a row that influenza activity peaked earlier than what we have seen on average, peaking the last week in December. Nationwide, it was the highest hospitalization rate on record. In the elderly population, there was approximately 319 hospitalizations per 100,000. The season began with a wave of H3N2, which was the predominant circulating strain this season from December through March. A second wave of influenza B, Yamagata lineages, started in March and carried us through June. It was a very interesting flu season. First, a majority of the H3N2 viruses that were circulating did not match this season's flu vaccine. Only 15% of the H3N2 viruses characterized actually matched the vaccine virus. This resulted in a reduced vaccine effectiveness. In terms of vaccine effectiveness, getting your flu shot this past season only reduced your chances of getting the flu by 23%. Influenza presented itself in some uncommon ways this past season. First, we had influenza mimic mumps. Many states reported to CDC of cases of influenza with non-mumps parotitis or swelling of the salivary glands. Parotitis is an uncommon symptom of influenza. As a result, a HAN alert was issued to detect cases nationwide. West Virginia had 11 cases of influenza-associated parotitis reported to the state health department, and we also participated in a nationwide study with CDC to interview cases and controls of influenza-associated parotitis. If that wasn't enough, flu began to present like measles. Several states reported cases of influenza B with maculopapular rash. The clinical significance of this syndrome is not clear. Rash is an uncommon complication of influenza and a very rare complication of influenza B virus infection. West Virginia had no reported cases of influenza B with a maculopapular rash. West Virginia also has a surveillance system in place for influenza. West Virginia collects virologic surveillance similar to what CDC does, only on a statewide basis. We have two different sources of data for virologic surveillance. The graph on slide 14 shows the number of positive tests for influenza by type and subtype as reported by hospitals and referral laboratories by PCR or culture. Rapid tests are not included in the totals because of the low positive predictive values during times of low flu circulating across the state. This data is useful for assessing changes in influenza activity and the types of circulating viruses. On the left-hand axis, the y-axis gives us the total number of specimens isolated by these laboratories. The right-hand axis gives us the total number of reported cases of influenza-like illness. The second source of virologic data is through the West Virginia Office of Laboratory Service, or OLS. OLS is the World Health Organization collaborating laboratory. They report the number of respiratory specimens tested and the number of positive for influenza type A and B each week. OLS provides more specific data on the subtypes of influenza circulating. OLS subtypes all influenza A and influenza B specimens submitted to their state lab. This virologic surveillance also allows West Virginia to conduct surveillance for novel influenza strains. This data is a collection of specimens submitted by sentinel providers, hospitals, and outbreaks reported across West Virginia. A subset of influenza viruses that OLS collects are sent to CDC for further characterization, antiviral testing, and antigenic characterization. The second type of influenza surveillance West Virginia has is outpatient illness surveillance. We currently have two sources of data for outpatient illness. The first is influenza-like illness cases reported by physicians to local health departments. This has been a requirement per the reportable disease rule to report aggregate weekly totals. Influenza-like illness, or ILI, is defined as a fever greater than 100 degrees Fahrenheit and a cough and or sore throat without another identified cause. This graph on slide 16 shows you the temporal trend of influenza-like illness for the past 4 flu seasons. This is one way we measure the severity of the flu season here in West Virginia. This past flu season in blue is similar to the 2012-2013 flu season seen in purple. The other source of outpatient illness surveillance comes from our sentinel providers. West Virginia had 61 sentinel providers for the 2014-2015 season. Information on patient visits to these healthcare providers for influenza-like illness is collected each week and reported through the CDC U.S. Outpatient Influenza-like Illness Surveillance Network, or the ILI-NET. West Virginia also utilizes syndromic surveillance. Syndromic surveillance will be replacing outpatient illness reporting by local health departments starting this season. However, we will still have sentinel providers reporting influenza-like illness in each of our counties. Syndromic surveillance uses information on emergency department visits and hospitalizations from hospitals across West Virginia to track health-related data for public health use. The platform West Virginia uses is called BioSense, in which enrolled hospitals report chief complaints and final diagnosis visits for influenza-like illness as a proportion of total patients seen. This has been our second season that we have been utilizing this data to maintain situational awareness surrounding influenza. It allows us to determine the start and end of flu season and when the flu season peaks. On slide 19, we have a different view of syndromic surveillance for the past flu season. This graph shows and compares influenza-like illness reported by BioSense enrolled hospitals, seen in blue, versus local health departments in green. One of the goals of utilizing syndromic surveillance for influenza surveillance was the prospect of discontinuing paper-based reporting from local health departments. Paper-based reporting of aggregate influenza-like illness is time-consuming for local health departments and providers. There is also a great deal of variability of how each county is collecting this data. As you can see from this graph on slide 19, BioSense and local health department influenza-like illness provide comparable trends for the season, and both are able to pick up the start and end of flu season and when the season peaks. Suspect outbreaks or clusters are a Category 1 disease in West Virginia and should be immediately reported to your local health department. The state has an outbreak team that investigates influenza outbreaks routinely seen in schools, long-term care facilities, or other closed settings. The 2014-2015 flu season was very active for influenza outbreaks. A total of 86 influenza and influenza-like illness outbreaks were reported this past season compared to 17 during the 2013-2014 season, which was characterized as mild. This past season was comparable to the 2012-2013 season, which is the last season that an influenza A H3N2 virus predominated. A majority of the influenza outbreaks this past season were in long-term care facility settings at 79%, followed by schools at 13%, rehab facilities at 7%, and then we had one correctional facility with an influenza outbreak. Nearly a quarter of all these outbreaks were confirmed by PCR, and almost 75% were confirmed by rapid tests. We had 2 flu outbreaks that used absentee rates in schools and clinical symptoms rather than collecting specimens, which was acceptable given that flu was so widespread across the state at this time. A total of 68 long-term care facility outbreaks were reported during the 2014-2015 flu season. This season was characterized as severe for the elderly, which is supported by the number of long-term care facility outbreaks that was reported this season. Local health departments did a great job this season turning in outbreak reports. We received 90% of all outbreak reports for long-term care facilities this season. A summary of the findings show that nearly 70% of all facilities had standing orders for vaccination of their residents prior to the beginning of the flu season, and 76% encouraged healthcare workers to obtain flu vaccination prior to beginning of the season. Barriers that remain for the management of influenza outbreaks is a percentage of facilities having standing orders for antivirals for their residents during flu outbreaks at 29%, and over 30% of local health departments reported that facilities need to improve their timeliness of reporting to local health departments regarding flu outbreaks. Clinical presentation of influenza outbreaks in long-term care facilities can be complex. Many residents have underlying health conditions and may not present with your typical influenza-like illness, which is a fever greater than 100 degrees Fahrenheit and a cough and/or sore throat. The following chart is a bar graph of the clinical presentations seen in the long-term care facility outbreaks reported this past season. Because clinical presentation of influenza can be difficult to distinguish in the elderly, we encourage facilities to use a set of infection surveillance definitions that are specifically designed for long-term care facilities, called the McGear's criteria. On slide 24 is a chart of the case definitions used to classify influenza outbreaks in long-term care facilities. 82% of the facilities reported that they used a clinical criteria to meet the probable case definition and confirm the outbreak through laboratory testing. 55% reported that they relied on using the case definition for influenza-like illness. Nearly 32% used the McGear's criteria, and only 28% used a physician diagnosis or nurse diagnosis. Implementing control measures in long-term care facility outbreaks helps slow and stop the transmission of influenza in a facility. Almost 90% of the long-term care facility outbreaks reported that they implemented droplet precautions, limited group social and dining activities, and implemented active surveillance for respiratory illness. Also high on the list of control measures implemented was administering antivirals, restricting visitation, and cohorting staff to work with ill or well residents. Influenza is a notifiable condition from the West Virginia Reportable Disease Rule. For laboratories, influenza is a Category 5 disease. Positive influenza laboratory results by immunofluorescence, culture, or PCR are required to be reported within 1 week to the state health department. This is important for hospitals to know. If they do confirmatory influenza testing, they should be reporting this weekly to the state health department. For healthcare providers and facilities, influenza is a Category 4 disease. Influenza-related deaths in an individual less than 18 years of age are reportable within 1 week to the local health department. Influenza outbreaks are immediately reportable to the local health department. Please make note of the proposed changes to the reportable disease rule. This will affect the upcoming season, which starts October 4th. Influenza-like illness totals have been repealed from the reportable disease rule. Providers no longer need to report influenza-like illness to the local health departments, and local health departments no longer need to report this information to the Division of Infectious Disease Epidemiology. This is because we have implemented syndromic surveillance of influenza-like illness in our emergency departments using BioSense. Once this rule becomes official, a HAN alert will be sent out to all providers and stakeholders to notify them of the changes. Next, we will review the role of the local health department. A sentinel provider is a healthcare provider that conducts surveillance for influenza-like illness in collaboration through the State Health Department and the Centers for Disease Control and Prevention. A sentinel provider can be a provider of any specialty, such as a family physician, pediatrician, or internist, in any type of practice, which includes public health clinics, urgent care centers, emergency rooms, or student health centers. Data reported by sentinel providers in combination with the other influenza surveillance provides a national picture of influenza and influenza-like illness activity across West Virginia and the United States. It's one way that we maintain situational awareness about flu across West Virginia, and it helps determine the start, peak, and end of flu season, as well as indicating the severity of the flu season. This data is also helpful to provide guidance on prevention and control activities, vaccine strain selection, and on patient care. Local health departments are required to actively recruit and maintain a sentinel provider. When recruiting a sentinel provider in your county, it's recommended that you schedule a meet and greet. Local health departments are encouraged to review reporting guidelines for flu, how they should submit surveillance specimens weekly to the Office of Laboratory Services year-round, and reporting to the ILI-Net. Local health departments should maintain communication with their sentinel provider throughout the season, as you may need to rely on them for testing during an outbreak. Be sure to follow up with providers immediately who are not reporting, and keep the influenza coordinator updated on any changes, including a change in personnel or email addresses. Having an active sentinel provider is part of the program plan for local health departments and part of the Public Health Emergency Preparedness Grant. A sentinel provider that regularly reports is defined as a provider who reports to the ILI-Net greater than 17 of the 33 weeks from the beginning of October through the end of May. Finally, local health departments have the responsibility to report and investigate all influenza-like illness or influenza outbreaks. Outbreaks should be reported to the Division of Infectious Disease Epidemiology within 1 hour of notification. Health departments should maintain a supply of flu kits year-round. It's good to have 5 kits on hand at any time, including the summer months. The viral transport media in these flu kits can be used for all respiratory outbreaks. The media does have a short shelf life, so I encourage your health departments to schedule a time each month to make sure that your supplies are updated and the media hasn't expired. This will help eliminate any extra stress when you have an outbreak. Local health departments should assist with outbreak investigation, including collecting specimens, providing guidance on infection control, and tracking absentee rates for school outbreaks, as you are the boots on the ground. Local health departments should complete an outbreak report form for each influenza outbreak and send it to the Division of Infectious Disease Epidemiology within 30 days of closing that outbreak. Local health departments or regional epidemiologists should also provide routine surveillance feedback to facilities to help facilities improve their management of outbreaks. Responsibilities also come with being a sentinel provider. Once you have completed the enrollment form with your local health department and faxed it to the state, you will receive an ILI-Net packet prior to the beginning of flu season. These will go out late September and go directly to the provider. This will have your username and password to log on to the ILI-Net, as well as instructions for reporting. I ask that you use a valid email address as this is the primary way we communicate to sentinel providers and send out weekly updates. As a provider, we request that you access and report to the ILI-Net by 12 p.m. each Tuesday to report the previous week's data. We will review how to do this in a couple of minutes. We also request that you keep a supply of influenza kits on hand for surveillance testing. An ordering form will be provided to you in your enrollment packet. We will also review how to order kits in a few minutes. Providers should submit up to 5 nasopharyngeal swabs from patients presenting to their office with influenza-like illness symptoms. Providers are encouraged to submit these surveillance specimens weekly to the state laboratory. These patients do not have to be tested for influenza prior to submitting the specimens. We actually need both screened and unscreened specimens. This includes anyone presenting with flu-like symptoms, even during the summer months. These surveillance specimens are vital to the state surveillance program. Specimens are subtyped to determine what strains are circulating in the state, and a subset of specimens are sent to CDC for antiviral resistance testing and further characterization. Providers should contact their local health department with any changes to their enrollment forms, especially any changes with email addresses or contacts. We encourage providers to let their health department know if there are any barriers that they may be experiencing reporting or submitting specimens to the state lab. Lastly, in the event of a community outbreak, sentinel providers may be asked to help with specimen collection. For instance, if we have an outbreak of flu at a school, we may send several students over to the provider to collect MP swabs on the students for etiology confirmation of the outbreak. It's also important to understand the role of the influenza coordinator here at the state. The influenza coordinator collects and reviews surveillance data. This data is posted weekly on our webpage to maintain situational awareness. Surveillance data is collected and reported weekly to CDC in order to provide a national picture of influenza. The flu coordinator also leads investigations of pediatric deaths and antiviral resistance detected across the state. The influenza coordinator will send out communications throughout the season, including the Flu-Free West Virginia series, which helps stakeholders prepare for the flu season, and the weekly influenza partner email, which keeps stakeholders tuned in to the most up-to-date information about flu. We will also be providing feedback to local health departments on sentinel provider performance throughout the season. The flu coordinator responds to media requests, and we can also provide you talking points to speak with the media regarding the current status of influenza activity in your region or county. Lastly, the influenza coordinator provides influenza and other respiratory disease outbreak consultation. I want to bring your attention to several incentives that the health departments can use to promote becoming a sentinel provider. First of all, we offer free influenza testing. Providers can submit up to 5 surveillance specimens per week for strain identification and confirmation. This allows a provider to determine what strains are circulating within their community. Secondly, we have partnered with the Division of Immunization to provide free flu vaccine to participating providers and their staff. When a provider completes an enrollment form, they are asked how many doses of vaccine they need for their staff. This request is then approved by the flu coordinator and the Division of Immunization. An email will be sent out to all VFC providers notifying them that their vaccine is on their way. If they are not a VFC provider, the local health department will receive the provider's vaccine, and the local health department can coordinate with the provider to deliver the vaccine to the provider. Lastly, becoming a sentinel provider is a great way to give back to your community. Influenza surveillance cannot be accomplished without help from providers across the state. Having a sentinel provider in all of our counties allows us to track the spread of flu across the state and to provide recommendations based on the data received. As a sentinel provider, you will have the knowledge to provide to your patients what is going on in their specific community. Initial enrollment of sentinel providers should almost be complete. Materials for sentinel provider recruitment can be found on our website at any time during the year. The link is provided on your slides. Counties may recruit providers year-round. Providers must complete an enrollment form to participate in the Influenza Sentinel Provider Program each season. Please fax your completed forms to DITE at 304-558-8736. CDC will assign a password and an ID and send the work folders to the state. We will then send out the work folders to Sentinel providers directly before the beginning of the season. Work folders may be delayed if you are in a county that has not submitted their enrollment forms by the deadline of September 4th, which is tomorrow. Sentinel providers will be mailed their work folders before the beginning of the season. The work folder contains your provider ID and password. Providers need to access a U.S. patient influenza-like illness surveillance network or ILI-net by 12 p.m. each Tuesday to report the previous week's data. Providers log on to the ILI-net using their provider ID and password. The link to the ILI-net is provided on slide 38. Slide 39 shows a screenshot of the ILI-net. Once you are logged into the ILI-net, providers will click to enter their weekly ILI report. A provider will then record their information on the data input page. Providers need to report the number of cases of influenza-like illness by age group, and then the total patients seen during the reporting period. It's important that providers submit this data weekly to establish reliable trends so we can identify increases in activity or distinguish patterns. In addition to reporting online, providers are encouraged to collect nasopharyngeal swabs on patients with flu-like symptoms to be sent out to the Office of Laboratory Services for testing and typing. In order to have a surveillance program that can determine the beginning and end of flu season, and to monitor the prevalence and spread of flu throughout the year, we must receive both screened and unscreened specimens to the state lab. This means that if a patient has had a rapid test or other influenza test, the specimen is considered screened. Providers may submit up to 5 specimens per week to OLS. We encourage to submit specimens year-round, even during the summer months when we typically do not see flu. This helps us to detect novel strains of influenza. Flu kits. It's recommended that each local health department and Sentinel provider should have 5 flu kits on hand for respiratory testing and to respond to outbreaks. Included in your flu kit is packing instructions, collection instructions, viral transport media, which needs to be refrigerated, a return shipping container, a label, and a cold pack. You can order flu kits by going to our newly designed website. The address is listed on slide 43. Please click on the Sentinel provider icon. This is where you'll find the resources for all Sentinel providers. You always have the option to call the Office of Laboratory Services at 304-558-3530. Once you click on the Sentinel provider icon, a drop-down of resources will be listed with an explanation of each. There you will find your specimen kit requisition form, instructions for collecting a specimen, and a copy of the submission form if you need one. Next, I want to remind you of a flu kit reminders. Make sure you check the expiration dates of your viral transport media, as these have a short shelf life. It is your responsibility to keep the supply of these kits and to order new ones once you've depleted them. Local health departments cannot order flu kits for their Sentinel providers. Return shipping labels are created based on the address on the request form. When it comes out to mailing specimens, make sure your specimens have 2 patient identifiers on the specimen tube. Specimens must be kept refrigerated. If you cannot ship a specimen within 72 hours of collection, you may freeze a respiratory specimen until it can be shipped. Due to mailing constraints, please do not ship on Thursdays because the specimens will arrive on the weekend when nobody is at the lab. The lab can be open to run specimens for high-priority outbreaks or novel strains like avian influenza, but this needs to be arranged by calling the state. Sentinel providers are allowed to batch ship specimens if this is more convenient for them. Per the reportable disease rule, hospital laboratories are required to report positive lab results by PCR, immunofluorescence, or culture in aggregate weekly to the State Health Department via fax. We need screened and unscreened specimens for hospitals for surveillance. To accomplish this, we are requesting the first 5 influenza-like illness specimens that you test each week are sent to OLS regardless of the result. For surveillance purposes, the state is particularly interested in early and late season isolates since we have a lot of false positives associated with rapid flu tests, and this helps with the detection of novel viruses. The state is also interested in specimens from hospitalized patients, those who may have a unique clinical presentation, or have reported international travel. On slide 47, here's a screenshot of the form used by hospitals that need to be submitted. This can be found on our website by clicking on the local health department icon and is listed under the required forms as weekly report for labs. For this report, any laboratory that does confirmatory influenza testing will report the total number of influenza positive specimens by subtype if available and the total number tested. The total number of specimens tested is new this season and is a requirement for national surveillance as an indicator to maintain situational awareness and to make sure that West Virginia is testing enough specimens to pick up on a novel virus if one was circulating in West Virginia. We are in the process of validating some hospital laboratories for electronic laboratory reporting through the West Virginia Electronic Surveillance System, commonly known as West Virginia ADS. Hospitals with their data validated through this system provides real-time virologic data to the state no longer need to report through this paper-based system. Let's move on to outbreak definitions. We are frequently asked what is defined as an influenza outbreak. Outbreaks in a healthy population are defined as follows: an increase in absenteeism in association with influenza-like illness or a laboratory-confirmed influenza case. This would be in the school or workplace. Or 3 or more cases of influenza-like illness in a congregate setting within a 3-day period, such as a daycare or sports team. The last outbreak definition for healthy population is 2 or more confirmed laboratory cases of influenza within a 3-day period in a congregate setting, such as a classroom or daycare. Outbreak definitions in long-term care facilities. First definition used is 2 or more cases of influenza-like illness occurring within the 72 hours should prompt for testing for flu. 1 test in conjunction with other compatible illnesses indicates an influenza outbreak. So that's 1 influenza test in conjunction with other residents that may be symptomatic with flu-like symptoms. Outbreaks are immediately reportable to the local health department, and local health departments are to report within 1 hour to DIDE. Case ascertainment of elderly residents with respiratory illness can be challenging. Using the McGear's criteria can be very helpful in determining whether you're dealing with an influenza, pneumonia, or lower respiratory outbreak. McGear's case classification worksheets for respiratory illnesses in long-term care facilities can be found on our website under the local health department icon under the long-term care facility outbreak toolkit. Routine annual influenza vaccine is recommended for all persons aged 6 months or older who do not have contradictions. Optimally, vaccination should occur before the onset of influenza activity within a community. Healthcare providers should offer vaccination by October if possible. Vaccination should continue to be offered as long as flu is circulating. Children aged 6 months through 8 years of age who require 2 doses should receive their first dose as soon as possible after the vaccine is available, and the second dose equal to or greater than 4 weeks later. The 2-dose recommendation for children 6 months to 8 years of age is for children during their first season of vaccination. So those are children who have never been vaccinated. While there are many types of flu viruses, a seasonal flu vaccine is designed to protect against the top 3 or 4 viruses that research indicates will cause the most illness during the flu season. It takes about 2 weeks after vaccination for antibodies to develop in the body and to provide protection against the flu. Traditional flu vaccines are made to protect against 3 different flu viruses, are called the trivalent vaccines. Quadrivalent vaccines are also available that protect against 4 different flu viruses. 3 kinds of flu viruses commonly circulate people today: Influenza A H1N1, Influenza A H3N2 viruses, and Influenza B viruses. Each year, 1 or 2 of the viruses of each kind are used to produce a seasonal flu vaccine. There has been some changes to this year's flu vaccine based on what we saw last year with the drift of the H3N2 virus. For this season, all flu vaccines will have the 2009 H1N1 virus, an updated H3N2 virus, and a Yamagata lineage influenza B strain. The H3N2 and the B strain have been updated for this season. The quadrivalent vaccines available will also protect an additional B virus of the Victoria lineage. Starting in December of 2014, highly pathogenic avian influenza H5 infections have been reported in the United States. These detections were found in domestic poultry, including backyard and commercial flocks, captive birds, and wild birds. There have been detections currently in 21 U.S. states, with 15 states having outbreaks in domestic poultry, captive birds, and 6 states with detection in wild birds only. Currently, there has been no human infections with the H5 viruses that have occurred, although similar viruses have infected humans in other countries. People in contact with known or possibly infected birds are at greatest risk and should take precautions to protect against infection. The map on slide 53 is a map of the United States with confirmed avian influenza in poultry since December of 2014. Since December, there have been 223 detections. Over 48 million birds have been infected. Outbreaks have started to decline in the Midwest, which is expected during the summer months. The last detection was on June 17 in a commercial egg-laying chicken flock in Iowa. The CDC has been working with affected states on appropriate human measures. This includes updated guidance for laboratories, worker safety, and updates for clinicians on their website. CDC has also been studying the human risk posed by these H5 viruses. In recent findings of one of their studies, it indicates that these H5 viruses detected in the United States were less lethal in mammals and replicated at a lower level than the H5 bird viruses from Asia that have caused infections, including serious illness and death in people. Overall findings suggest that these new U.S. bird flu viruses are unlikely to easily infect or spread between people in their current form and are likely to be associated with moderate illness compared to more severe illness associated with the avian H5 viruses. Ultimately, these bird flu viruses would need to undergo additional changes in order to pose a pandemic health risk to people. Lastly, CDC is currently evaluating the vaccine they have in the Strategic National Stockpile to see if the vaccine they have for H5N1 may be used towards a vaccine candidate. West Virginia has been busy the past few months watching the situation develop in the Midwest, and they have been meeting with stakeholders to discuss West Virginia's response. West Virginia is preparing for the if and when high path is detected within the state. If high path is detected in the state, it would be a multi-agency response involving DHHR, the West Virginia Department of Agriculture, and USDA. It's likely that the governor will declare state of emergency to help organize available resources. West Virginia, along with many other states, have decided to cancel bird and poultry shows at state and county fairs this season as a precaution. Our laboratory has also been busy preparing for in the event testing needs to be done at our state laboratory to rule out a human case of high path, even though it is unlikely at this time. The state laboratory accepts any positive influenza specimen for subtyping, and they are the only laboratory in the state that has the H5 reagents that can detect high path. Within our office, we've been updating our avian influenza surveillance protocol and been working closely with the West Virginia Department of Agriculture to address our response to maintaining worker safety and health monitoring of persons exposed to high path during response efforts. Clinicians should consider the possibility of infection with a novel influenza A virus with the potential to cause severe illness in humans and patients with medically attenuated influenza-like illness or acute respiratory infection who have had recent contact with sick or dead birds. This includes domestic poultry, wild aquatic birds, captive birds of prey that have had contact with wild aquatic birds. If an infection of novel influenza A is suspected, please contact your local health department immediately for guidance on testing and taking the appropriate infection control measures. Testing for other respiratory viruses is also critical as part of an evaluation for persons with respiratory symptoms who may have been exposed to sick or dead birds. We ask that you continue to submit routine surveillance specimens for influenza testing to the state laboratory. We also ask that you maintain situational awareness regarding high path by reading our weekly influenza partner emails, paying attention to any HON alerts that are released, and new documents that may be added to our website. Although the current situation does not indicate human-to-human transmission of high path between humans, things could change in the fall time. This situation has the potential to impact all counties in West Virginia. A resurgence of high path is expected this fall with cooling temperatures. West Virginia potentially could see high path in any backyard flocks, which are in all of our counties. And West Virginia has approximately 432 poultry farms in 8 counties, seen here in blue, that could all be impacted. So just in case I haven't given you enough information this afternoon, we have a weekly influenza partner email that you can sign up for if you don't already receive them. Just please email me. The Flu-Free West Virginia series is one-page fact sheets for flu partners to help prepare for the flu season. These will start to go out next week. The Division of Infectious Disease Epidemiology has an awesome flu webpage that has our surveillance data and lots of great resources for a variety of audiences. The CDC has their own influenza website. And then lastly, the Division of Immunization also has a website related to flu and flu vaccines. That concludes my presentation for the 2015-2016 influenza season. Right now we're going to take some questions. You may submit a question by clicking on the question and answer tab at the top of your screen. Please type your question and then click ask. Do you have questions?
We have one. The question is, being a very small county, if every facility is a Sentinel provider and reports to the ILI net, does the local health department still need to fax the reports weekly?
As I mentioned previously in today's presentation, starting for this current season, local health departments do not have to report influenza-like illness from providers to the state. That is being discontinued for the new flu season. So if you've got a couple of Sentinel providers that are reporting to the ILI net, that's all you need to do. There's no other action needed by local health departments. This is supposed to ease the work of local health departments because they don't have to collect that information. All right, well, if there's no other questions, I want to provide you with, never mind, we have another question.
The question is, if we get ILI reports from the school, do we tell them not to report ILI anymore to us?
Yes, it is no longer required for schools to report influenza-like illness to the local health departments unless that is a local decision that you guys have made previously. I know in the Mid-Ohio Valley region that is something standard that their region has implemented, so that is a local decision whether they want schools to continue that report or not. So, but it is not a reportable disease requirement. Last call for questions. Okay, on slide 60, I just want to sum up some important contacts. Myself, the influenza coordinator, my name is Shannon McBee, and there's my contact information. I do want to let you guys know that I am going to be going on maternity leave at the end of September. Our vaccine preventable disease epidemiologist, Stacy Tressler, will be the acting flu coordinator while I am out on maternity leave. I'm expected to return just as hopefully flu season is at its peak. My return date should be January 4th, but you have my contact information and Stacy's on slide 60, as well as Lori Tyson, who is responsible for collecting a lot of our data, the Office of Laboratory Services, the Division of Immunization Services, and always, if you have any questions about flu or outbreaks or you need to report something, our reporting consultation line and outbreak reporting line. Thank you guys all for taking your lunchtime to listen to the 2015-2016 flu season. Thank you guys.